Very fortunate to have a guest speaker today. Dr. David Kirschke is well known to all of us. He is the medical director for the Northeast Region Health Department for the Tennessee Department of Health. Also one of our adjunct faculty who co-teaches, interestingly, infectious disease epidemiology. David got his undergraduate degree at Holy Cross, his medical degree at the University of Florida, trained as a family doc, and then joined the Epidemic Intelligence Service at the CDC, was assigned to the Tennessee Department of Health, worked there, worked here in the Northeast, and went down to Nashville as the Deputy State Epidemiologist before coming back as our medical director. A good friend of our college and a good friend of mine. Please welcome David Kirschke.
So actually Dr. Wyckoff titled this for me, Public Health, Ebola, Public Health Implications or Implications for Public Health. But I was going to ask you all what you all think the public health implications are of this very large Ebola outbreak. Before I tell you what I think they are. You might have some better thoughts than I had. So maybe we'll get on a tangent and talk about that. I'd also encourage you to, at any point during my presentation, to interrupt me and ask questions. So that's a good question. We will talk about vaccines, but there are 3 vaccines that are in phase trials that are in, I think, phase 1 trials. But I don't know exactly how many different laboratories are working on them, but there are 3 different candidate vaccines that are in clinical trials, or maybe not clinical trials, they're in some kind of trial.
Versus later response.
Right, so if you respond quickly to something rather than kind of sit around and watch what happens and then try to respond later after it's gotten out of control. It's kind of like firefighting. If you stand around and watch the forest fire for a long time and then try to do it, it's going to take a lot more resources and probably be a lot more of a problem. So actually, one of the things you just said. So weak public health response equals poor outcome. I also think there are some instances where strong public health response has yielded good outcomes during this outbreak, and we'll talk about that. Sound epidemiology should guide public health measures. So we've heard there's obviously been a lot of different people saying how they think things should go. Not all of them, trained in public health. We'll talk a little bit about that. Effective public health communication is critical. So both in the prevention and control messages that are going on in West Africa among the people that are affected. So initially in West Africa, there was not a lot of understanding. There had never been an outbreak in West Africa before, so there wasn't a lot of understanding among the population there, how Ebola was transmitted, what it was, how to prevent getting it, how to take care of someone that's sick. And then risk communication messages, and over there and in the United States, there's a lot of things. You go on the internet and you can just find all kinds of different things on the internet saying all kinds of different, scenarios. And then lastly, a public health threat anywhere is a public health threat everywhere. So we do live in a world where, people can travel rapidly around the globe. We saw that with SARS, where there was one case in a hotel in Hong Kong, and then that eventually spread to, I think, like 12 or 13 different countries from that one hotel. And we're starting to see that with this outbreak as well. So I'll talk a little bit about the setting of the outbreak, the epidemiology, because I think we have some epidemiologists in the crowd today. Talk about the evolution of the outbreak, what's gone on with the response, and then we'll circle back to the public health implications. Ebola, the first recognized outbreak was back in 1976. Since then, there had been 20 outbreaks before the current outbreak in 10 different countries, mostly in very remote areas, villages and things like that are really far away from large population centers. So even though they were devastating, they did not have that potential to cause a really huge outbreak just because the population in those areas was limited and there wasn't a lot of travel going on back and forth. So the current outbreak is affecting primarily 3 countries, Guinea, Liberia, and Sierra Leone in West Africa. Largest documented outbreak, so there's already way more cases and deaths than there ever was in the previous 20 outbreaks. So as Dr. Wyckoff said, about 15,000 cases and over 5,000 deaths so far during this outbreak. So countries with cases, again, those 3 countries I mentioned and West Africa are the primary countries affected by the outbreak. There are currently cases in Mali. I don't think there's a current case in the US. There's been 4 cases that have developed, 4 persons that have developed Ebola in the United States, one of whom died since 1976. There has been some time to investigate it, but these outbreaks have been in remote areas and things like that. And it's been sporadic outbreaks. So there is some things we can still learn about Ebola. But it's thought that the most likely reservoir is fruit bats, which it has been found in, as well as some other animals. The first patient that they think probably is infected through contact with animals that are infected with Ebola. Once that occurs, it can be transmitted human to human, primarily through direct contact with body fluids of an infected person after they've developed symptoms, so blood, vomit, diarrhea, things like that. It can also be transmitted what we call nosocomially, so in a hospital setting between a patient and a healthcare worker, or between patients in a hospital through something like a needle stick. So if you're drawing the blood of a person with Ebola and you got stuck with the needle, it would be a very dangerous situation. So the symptoms of Ebola, unfortunately, they're not very helpful in telling if it's Ebola or not. They're what we call nonspecific symptoms, so it looks just like the flu or a lot of other illnesses. So just, I feel like I'm in everybody's way standing up here. So just by looking at someone, you cannot tell that it's Ebola. So fever, headache, body aches, things like that go along with a lot of different illnesses. Once you get really sick and start having hemorrhagic problems, then it kind of narrows the differential diagnosis down a little bit. Or you might be suspecting it, but a person could be sick for a while before you might suspect Ebola, unless they have an epidemiologic link to a case or travel history. So hemorrhage, the main thing people think about with Ebola is the hemorrhagic. It's a viral hemorrhagic fever and people having unexplained bleeding. That happens in about 18, it doesn't happen in everybody, it happens in about 18% of patients, and the primary manifestation is blood in the stool. So when they go to bloody diarrhea. The epidemiology, so the incubation period, which is a time between when you're exposed to someone with Ebola and when you develop an illness, is typically 8 to 10 days. We think that the outside limit is 21 days, and that's why you hear all the recommendations that people are, after they're exposed or after they travel from that area, they're monitored for 21 days. To make sure they don't develop symptoms, and if they do develop symptoms, to get them in isolation right away and treatment. People are only thought to be infectious once they develop fever and other symptoms. So before that, the amount of virus that a person has in their body is not high enough to transmit it. And then people become more infectious as the disease goes along. So the sicker you get, the more virus you have circulating in your body, and the more likely it is to transmit. Also, as the disease goes along, people start having vomiting and diarrhea and things like that, which, those body fluids will transmit it. People are also contagious after they die. So one of the problems early in the outbreak was that people would die of Ebola, and then family members, it's a custom in West Africa, as it is in many parts of the world, that people, in preparing the body for a funeral, would touch the body, and then people would get sick that way. So the epidemiology, the median age is 32 years, with most people between 15 and 44 years. Half are male, so it's pretty indiscriminate as regard to sex. 118 cases, or 7% among healthcare workers, so healthcare workers are largely affected. There's been other outbreaks where a quarter of the patients were healthcare workers. So being a healthcare worker, you're around the person when they're the sickest, and you're among the highest risk for getting Ebola. One of the things that was in the news earlier this week is this doctor from Sierra Leone that was treated here in the US but died. He was pretty sick when he arrived and died. But this article just reminds us that says more than 100 physicians in Sierra Leone have died, which they started out with, I think, 1 or 2 physicians for every 100,000 people in that country, and now a lot of them have died. So, they started out with pretty poor health and public health infrastructure to begin with, and it's only gotten weaker because, these people are getting sick and are being affected by the outbreak. So, since this is a crowd that contains some epidemiologists, I wanted to talk a little bit about where we get some of this, some of the data and the recommendations about how Ebola is transmitted. So transmission is thought to be largely with direct contact, specifically with contaminated body fluids of patients. So, where does this data come from? It comes from field investigations from past outbreaks. So an epidemiologist went out, interviewed a lot of people, figured out what their exposures were and how they got sick. So one outbreak in 1995 in the Democratic Republic of Congo, obviously they interviewed patients and also contacts. Of 28 of 95 family members of people who had Ebola, became and had direct contact with them became sick, whereas 78 family members who did not have direct contact with the sick person, none of those people got sick. So direct contact with a sick person looks like the primary risk factor. It's interesting, if you go back to the age data, a lot of kids, there's not a lot of children, or children don't represent a high proportion of people that are affected by the outbreak. And it's thought that when someone becomes sick, the kids are probably in this, in the cultures in West Africa, the kids are kept away from the sick person. It's maybe the mom, the grandmother, or someone like that that's taking care of the sick person and is more likely to get Ebola. Other studies report similar findings. So all or a large proportion of secondary transmission involves direct physical contact. So if you kind of look further, exposure to body fluids conferred additional risks. So you were 3.5 times more likely to get sick if, besides having direct contact with the person, you had contact with body fluids from the person. And then family members who touched a deceased patient had a 2 times elevated risk of developing Ebola. And also the risk was increased if you were around the person when they were at their sickest. So if they were close to death and you're around the person, you're at increased risk. So direct contact with a sick person looks like the primary way. You will, I think you may remember the patient in Dallas who died. None of his family contacts got sick. So all the people that were with him at his house, when he was not very sick, he was just starting to develop fever and things like that. So none of those household contacts became sick. But the healthcare workers that were with him in the hospital when he was really sick, having a lot of vomiting and diarrhea, and right before he died, are the people that got, the 2 nurses that got Ebola. So what other kind of exposures are we worried about with Ebola? So one is just touching the person's skin. So it's thought that skin contact is lower risk than exposure to body fluids. And there's a couple of thoughts about exposure to the skin. One, if someone's really sick, it's thought that, the virus can actually be on the skin coming out through the pores like in sweat. But the other possibility is that, when they're having a lot of vomiting and diarrhea, that their skin is contaminated with those body fluids. Indirect exposure, so fomites, so things that the sick person touches, are thought not to play a huge part, but there is one case. There was a person that was hospitalized in Uganda during an outbreak. He did not have Ebola. He also did not have a blanket, so a patient died with Ebola. They took the blanket from the person that died and gave it to this person, and he subsequently developed Ebola. And it's thought that it was transmitted by that fomite. However, in other outbreaks, they've looked at, they've gone through and done an environmental study where they test for Ebola in the environment, so like on the bed sheets and clothes and things like that. And they have not found Ebola on those things except where there's visible blood or body fluids. So those are the places you find it, but not necessarily just on the person's clothes or sheets. They also had the same experience at Emory University after they took care of the doctor and the other woman missionary. They actually went through the hospital or through the patient's room and sampled a lot of things in the environment and tested, and they did not find Ebola. That's a situation where you're in the hospital and there's a lot of environmental cleaning going on. So it's theoretically possible through fomites and through the environment, but it's less likely, and still the main risk factor is direct contact. So viral load. With Ebola, they describe, viral load describes the amount of virus you can find in the blood. And they describe the viral loads in sick people as being really high. So with HIV, we talk about viral loads, and we talk about viral loads in the millions. But supposedly with Ebola, they talk about viral loads in the billions, per cubic millimeter or whatever it is, cubic centimeter. So people have really high viral loads. Tests for Ebola, tests for the RNA of the virus. It's usually detectable when the person first starts having symptoms, but in some cases it takes about 3 days before you can actually detect the virus in the blood after they start having fever and other symptoms. And then the viral load, builds up greatly. They describe it as logarithmic increases in viral loads. So Ebola, how long does it persist in different body fluids? So in blood, it's thought to persist for about 21 days in the blood, or can persist up to 21 days. These are studies with very small numbers, so it may be longer in some cases. But in other body fluids, it can last significantly longer, like 101 days in semen. So you'll notice that when people are in the hospital, after they become well, they'll keep them in the hospital for some period of time while they continue to test their blood and make sure they're negative for the virus before they're released from the hospital. So transmission to healthcare workers, I mentioned before that healthcare workers are one of the groups that are most at risk. The other being household close contacts that have direct physical contact with the patient. So in that same Democratic Republic of Congo outbreak in '95, a quarter of the cases were among healthcare workers, and all provided care to Ebola patients without appropriate contact precautions. So contact precautions are gloves and gowns. So these are, again, resource poor areas. So the healthcare providers didn't even have gloves and things like that. So all these people became sick by caring for people without appropriate personal protective equipment. Once they initiated gloves and gowns, only one additional healthcare worker became ill during that outbreak. And it was a nurse who later described that she had, rubbed her eye with a contaminated glove while she was caring for a patient. Another example is in South Africa. There was a patient that was hospitalized with Ebola. It was just one case, so it wasn't during an outbreak, so people were not suspecting Ebola. And this person was in the hospital for weeks, I guess 2 weeks before they figured out it was Ebola, and had contact with over 300 healthcare workers, only one of which developed Ebola. And it was someone that was putting in a central line, so a procedure that involves a lot of blood and things like that. And there's some speculation whether that person might have had a needle stick injury, which would be high risk for developing Ebola. But it does suggest that just that contact precautions of wearing gloves and doing what we call standard precautions in hospitals now, if don't touch people's body fluids, don't touch blood, vomit, and things like that, will protect most healthcare workers. Obviously, if you see, you've seen pictures of people that are taking care of people. Obviously, you want to add some extra layers of precaution, so people use additional PPE, but really just avoiding contact with the person is the primary way to avoid getting Ebola. So there has been some speculation about airborne spread of Ebola. So it is experimentally possible to aerosolize Ebola and make, for instance, they've done it in laboratory animals where they've made a mist out of Ebola and sprayed it in a cage of a monkey, and the monkey developed illness with Ebola. But there's not been any documentation during human outbreaks that airborne spread is a way that people have gotten sick, although it's theoretically possible. So, for instance, again, in that same Democratic Republic of Congo outbreak, there was 12 Ebola patients, which was only like 3% or 4% of the patients who did not, when they interviewed them, did not say that they had direct contact with a person with Ebola. So that raises a question, well, how did they get Ebola? So of these 12, apparently none of those 12 were laboratory confirmed Ebola. So it's possible that some of them didn't have Ebola. They might have had something else like malaria, but it was an Ebola outbreak, so probably most of them had Ebola. So exposure histories for 10 of the 12 were provided by someone else besides them, so they were too sick perhaps to give a history, so they had to interview a family member. So it's possible the family member just didn't know about all their exposures. They also did not rule out transmission via droplets or fomites. So droplets is if you're within 3 feet of someone and they cough directly on you, like right in your face, and it goes right in your mucous membranes. So that was not ruled out. However, all 74 patients with confirmed Ebola, laboratory confirmed Ebola, all had histories of direct exposure. The other reason we don't think, well, the other thing from this outbreak that kind of would suggest that airborne's not a main way to spread is that people that had a cough or were coughing a lot did not have more sick contacts than people that were not or did not transmit Ebola more than people who were not coughing. So treatment with Ebola is supportive. There's no known treatment. There are several investigational therapeutics in development. So you may have heard that some of the patients were treated with this thing ZMapp, which is kind of antibodies against the virus. Also, other people have been given transfusions of antibodies taken from people who have had Ebola and have recovered. But the jury's still out on whether either of those therapies are helpful. Vaccines, again, there's no current vaccine. There's 3 vaccines that are in phase 1 trials. So they're still looking at the safety of the vaccines before they can start trying them in humans, I think is what that means. Although we'd probably accept a pretty low efficacy in a vaccine if we could get one. It's kind of like with HIV, and even if it was like 50% effective, it could still potentially have some use.
You mentioned that HIV vaccine. Where are we with that?
We still don't have one.
Right. Exactly.
Yeah, I don't know. Good question. So I'm going to talk a little bit about the evolution of the outbreak. So there have been some news reports reporting on who they think is the initial patient or patient 0, who's the first case in this outbreak. And it's thought that there was a 2-year-old in Guinea who lives in a rainforest area in Guinea who became sick. That's still not clear about how that 2-year-old became sick, whether it was contact with animals, which would be the most likely thing, unless there is some other unknown case around. But from that one case, there's people that took care of that 2-year-old, and there's family members that traveled to the funeral and things like that, and then traveled to other countries. But it looks like that's where the outbreak started. If you look at the epidemic curve, which is the number of cases by week in this outbreak, and so the different colors represent the different countries, but as someone mentioned in the beginning, we just really missed a really big opportunity to get on top of the outbreak initially. I think the World Health Organization was not notified until about March of the Ebola outbreak. But certainly after March, you can see there was still a lot of time where, the global public health community were dragging their feet a little bit. So the experience from all these other outbreaks was that they're in remote areas and they would kind of burn themselves out all by themselves, even if you really didn't do a whole lot. Unfortunately, this outbreak was in an area right on the border of 3 different countries with a lot of travel routes, people traveling back and forth between the countries and between large population centers. And so it really quickly got momentum and started the number of cases increased quickly. Besides the public health community kind of dragging their feet and getting involved with it, there's been reports that it's been hard to raise money, after the hurricanes and the earthquake in Haiti, there was just floods of donations to all these different groups to help out, but it's been a lot less so with the old Ebola outbreak. So this was a report on NPR Planet Money, just talking about, it says, from the viewpoint of philanthropy, the Ebola outbreak is the opposite of the Haiti earthquake. It's far from the U.S., hard to understand. The outbreak emerged over a period of months, and it wasn't clear exactly in the beginning how bad it was going to be. Luckily now there are some big donors that have stepped in and things like that, but even still, I don't know, the CDC a few months ago had put out a request for people to volunteer to go over to unaffected countries in West Africa to help them get prepared to do surveillance and things like that, which I had thrown my name in the hat, but I got an email back that there wasn't enough money to fund the thing, which is kind of sad. So between CDC and other groups didn't have enough money to kind of help these other countries get prepared. So the situation, it sounds like recent reports that things are starting to get under control, but as of a month ago, the doubling time was about every 20 days. So for Sierra Leone and Liberia, the number of cases were doubling every 20 days, which at that time the projection was that there could be 500,000 cases by mid-January of 2015. Unless some public health measures were instituted. So on August 8th, the World Health Organization declared this was a public health emergency of international concern, so kind of like a wake-up call that all the other countries in the world can't just ignore it, because it will start spreading outside of the borders of those 3 countries. And so indeed, on September 30th, laboratory tests for the patient in Dallas came back positive for Ebola in the person that had traveled from Liberia to Dallas. I won't go through the whole timeline with that patient, but I think we all know that there was confusing public health messages, there was mistakes made, they had problems in the health care, in the medical care of the person. 2 nurses who cared for the person became sick with Ebola. There was lots of contacts. Some of the contacts were allowed to travel when they shouldn't have been traveling, and the ball got dropped there. It also brought up a lot of medical management issues that for hospitals in the U.S. About recognizing potential cases. So all of our hospitals now are, when you go in the emergency room, hopefully they're asking you if you've traveled anywhere outside the country in the last 30 days. Or 21 days. They all have identified isolation rooms, so if someone does come in and has a positive travel history and is sick, our state lab can now test for Ebola. Personal protective equipment has been a big issue. So CDC originally came out with, you need a pair of gloves, a gown, a face mask, and a face shield. And then nurses' unions, especially after the 2 nurses got sick that were following those recommendations, whether they made a mistake taking off the PPE or the PPE wasn't adequate. Now they've gone and there's whole new recommendations for increased levels of protective equipment. One thing we do know is that you can wear all the protective equipment in the world, but if you don't take it off right, you're going to contaminate yourself. So the recommendation is to always have someone else with the person taking off the PPE to make sure they don't inadvertently touch themselves or contaminate themselves by touching the outside of the protective equipment while they're taking it off. We're learning more about medical management of patients. So in the Africa context, there wasn't a lot of ability to do lab work on these patients, but patients that have been taken care of here, they've been able to do lab work and seen that their electrolytes are fluctuating. They're losing tons of fluid. It's almost like cholera is how the doctors from Emory described it. They were losing 5 to 10 liters of fluid a day, and they could almost not keep up with replacing all that fluids that they're having vomiting and diarrhea, losing so much. It was hard to keep up with. Environmental cleaning and waste. So there's issues around, how do you dispose of the waste and the sewage and things like that. New England Journal of Medicine, World Health Organization, one of the response teams published an article about the first 9 months of the outbreak in the New England Journal of Medicine. And one of the things they say is that we infer that the present epidemic is exceptionally large, not principally because of biological characteristics of the virus. So there's a lot of talk, oh, the virus is mutated and becomes some kind of super virus, but rather because of the attributes of the affected population. So the population where the outbreak's occurring, we'll talk more about that, and because control efforts have been insufficient to halt the spread of the infection. So to address whether a lot of times, people ask about, has the virus mutated and become some kind of super virus? So the current outbreak strain looks like it's very closely related to the two most recent outbreak strains from Central Africa. As observed previously, there's small mutations in the virus. It's currently not known if these changes have had any impact on disease severity or transmissibility. However, from all the epidemiology, it looks like it has the same transmissibility, so the same routes of transmission, and also about the same case fatality rate and things like that. So it's acting pretty much like previous viruses have. So geographic dissemination, I talked about this a little bit already. So where this outbreak occurred was in an area where there's multiple borders, where people are crossing back and forth close to very large population centers. But they also say the critical determinant of epidemic size appears to be the speed of implementation of rigorous control measures. So it's not just the factors associated with the virus or with the population where it's at. The primary consideration is how quickly rigorous control measures were implemented. Because we'll talk about in a second, there was a case that went to Nigeria, to Lagos, Nigeria, which is a huge population. So there definitely could have been just as big an outbreak occurred there, if not worse. But we'll talk about how they implemented control measures. So this was an MMWR article. It was talking about mathematical models of how big the outbreak could be and how soon implementation of control measures need to be implemented to start to control the virus, to control the outbreak. So it's kind of intuitive anyway, but obviously the sooner you implement effective control measures, the less steep the curve is going to be of how many cases occur eventually. Yeah, it definitely looks like the initial cases they suspect probably occur because of contact with animals, either through eating bushmeat.
Right.
So some people will hunt animals and eat them, and while preparing them, you could come in contact with the body fluids. But then once a human gets it, it can be transmitted person to person. Yeah, so fruit bats, they think, are probably the primary suspect, but it's also been found in like these small antelope that occur in Africa, also in non-human primates, so monkeys. So it's not clear 100% which exact animals. And with that patient 0, that 2-year-old, I don't think they ever found a history of that person having contact, but with a 2-year-old, you can't exactly get the full history from them. We expect all our Tennessee hospitals to be able to evaluate a patient with possible Ebola. So if someone comes in with fever and they say they've just come from West Africa or they've had contact with a patient with Ebola, we expect them to be able to isolate them, put on appropriate personal protective equipment, ask the appropriate questions, and do tests to try to figure out if they have Ebola. But then our recommendation is probably going to be that they transfer them to one of these specialty hospitals like Emory and like Nebraska that have just had more experience in taking care of patients. So I don't know. I don't know enough information to know exactly what went wrong, but we do know, obviously 2 nurses got sick, so something happened with their personal protective equipment and things like that. The patient died. One of the problems was, so there have been 10 patients that have been treated in the U.S., and the 2 people that came from West Africa that were native of West Africa both died, but they were both they were the sickest patients when they got to the hospital. So Mr. Duncan, unfortunately, came to the emergency room early on in the illness, but they didn't, someone asked a travel history, but didn't get communicated to the right persons. So he was discharged, and then 3 days later came in after he was having vomiting, and he was already pretty sick. And then the doctor that I mentioned that died this week also was very sick when he was admitted. So it's hard to tell what happened there, but I don't know. It looks like getting treated early is good. And then again, I think that we would, if there is space available in one of those specialty referral hospitals, if the hospital asks us, we would recommend that they transfer them to probably one of those facilities that just have more experience. Going back to the implications for public health. So we already talked about the first one. So if you have a weak public health response, you're going to end up with lots of cases and a poor outcome. I did want to talk about a situation, strong public health response leading to a good outcome. So there was a case of a person that was from Liberia. I can't remember, I think it might have been a physician or some kind of healthcare worker, but he was hospitalized in Liberia for suspected Ebola. He did not either want to believe the diagnosis or whatever, but he checked out of the hospital on his own against medical advice. And then 3 days later, he traveled to Nigeria, to Lagos, Nigeria, where he became sicker and had to be hospitalized in Nigeria. Initially in Nigeria, he denied that he had had any exposure to Ebola. So he had lots of contact with lots of healthcare workers and other patients in the hospital. So he eventually exposed 72 people in the hospital and on the airplane. They were treating him because he had denied any exposure to Ebola, they were treating him for malaria. But eventually that wasn't working, so they again suspected Ebola and figured it out. But by that time, again, there were 72 different contacts. 13 of those contacts developed Ebola. This patient died on July 25th. Public health measures in Nigeria were instituted. Nigeria has a fairly robust public health system, and they have a lot of educated public health workers and actually healthcare workers too. So they were able to do a lot of contact tracing, track down all these contacts, and get them into quarantine, and if they got sick, isolate them. So they were eventually able to stop this outbreak after 3 generations. So from those 13 people that got infected by the first person, there was 3 additional people that got sick. Actually, I'll show the. So these are this is the original patient. 13 people got sick associated with that first case. Among those 13, one of them kind of slipped through their public health net, so they weren't able to figure out where that person was. But that person had traveled to another area of Nigeria, so they lost track of that person. There was 3 subsequent cases of Ebola from those original 13. They eventually figured out where this person was, and then there was 3 more cases, but then it stopped after that. And since then, the World Health Organization has declared, it's been 42 days, which is 2 times the incubation period. So they've declared that Nigeria is Ebola free. So that was on October 20th. So again, strong public health response yields a good outcome. So sound epidemiology should guide public health measures. We talked a little bit earlier about how there's been different messages and things like that come out from different people. This was kind of a spoof thing that was in the New Yorker magazine related to some of the things the governor of New Jersey had done while quarantining a healthcare worker that was traveling from West Africa. There also have been other communication problems. So this was something in the media where Dr. Frieden, Tom Frieden, the director of the CDC, apparently said that you can give, but you can't get Ebola on a bus, which sounds like a confusing message. But apparently his boss had at some point said that you can't get Ebola just by riding on a bus. So he was asked, a direct question from some reporter who asked, can you get Ebola on a bus? So he couldn't say that his boss was wrong. So he had to end up saying something crazy like this. So sometimes it's hard, when you have public health people and you have politicians and other people. I don't know, sometimes the messages aren't totally coordinated and it doesn't always go based on sound scientific things. I will say, with governors, they're the ones that are ultimately responsible for what happens. So there is a lot of pressure on them to protect the community. So hopefully they're communicating well with their, commissioners of health and things like that to get the message right. But it does eventually fall down to them to actually make the decision. So, it would be hard to be in any of those people's position. So it's a lot of pressure, but some of them, I think in Tennessee, our folks have gotten it pretty right in how they're going about it. So in Tennessee, we have obviously had people that have traveled to Tennessee from West Africa. Our policy is that, and now, so before they started monitoring people coming off of airplanes, so now when people travel here from West Africa, they do get contact information from everyone traveling from that area and give it to the health department now. But even before they were doing that, we were going out looking for people just so we could educate them about monitoring their symptoms for 21 days so that if they did have any symptoms, they can get into healthcare right away, also get isolated so they can't transmit it to anyone. But I think in Tennessee, we've had a pretty good balance of, strong public health work and also good messaging. So effective public health communication, again, we talked at the beginning that, it was in the beginning of the outbreak, a lot of transmission was occurring just because people did not understand how Ebola was transmitted and what to do and what not to do. So there's been a lot of efforts by UNICEF and ministries of health of these countries and CDC and other people to get the right messages out. And then finally, public health threat anywhere is a public health threat everywhere. So back in the middle of August, the Tennessee Department of Health actually put out what we call a health alert to all the healthcare providers in the state, talking about screening people for travel history, one because of Ebola, but also because of something called Middle East respiratory syndrome, which is a SARS-like illness that has been occurring in the Arabian Peninsula. But there's also other things. There's measles, so we've had some imported cases of measles in Tennessee this year from a large outbreak that's going on in the Philippines. We've also had cases in Tennessee of chikungunya virus from a big outbreak that's going on in the Caribbean right now. So just a reminder that a public health problem going on anywhere in the world is eventually going to come back because of how people travel. And along with that, there's a lot of other things that contribute to that, to those problems. So I think I'll end there and hopefully have time for a couple of questions. Yeah, so I think that there was a case, Marburg virus as kind of a sister virus to Ebola. It's a similar virus. And there has been documentation of a patient that had Marburg virus, recovered, and then about 3 months later had sex with their partner, and then the partner developed Marburg virus because of that. So it does look like some of these viruses, even though you can't detect them in the blood anymore, they can survive in certain body fluids. So there is, certain parts of your body are kind of segregated off from your immune system, like your brain. There's something called the brain blood barrier, and it's also like testicles and things like that are segregated from the immune system. So there are places, like with HIV, we know that the virus hides in lymph nodes and places like that. So there are some places that looks like the virus can hide. And I don't know specifically, but I assume that they give the patients, when they're discharged from the hospital after recovering from Ebola, they're given a recommendation probably not to have sex for some period of time, and I don't know what that period of time would be. Because the cultural, for one, there's a lot of people in Liberia has just been through like 2 civil wars. you know, a lot of people aren't trusting the government, obviously, because there's that civil conflict has been going on. So there's a lot of distrust of the government and things like that. But yeah, really, that I think initially that was the big challenge, is getting one credibility or someone that's credible. So the other people besides the government that they didn't trust, then they had people coming in moon suits, you know, walking around telling them what to do, and they look like aliens or something like that. So yeah, I think having someone that's credible that can, so I mean, that's one important thing about having a good, credible, strong public health infrastructure and already in place. Whereas we know some of these resource poor places, you know, just don't have that ahead of time. Yeah, and I think there's a lot of people in this area that aren't that into cremation either. So I think it would disturb a lot of people if someone, so what they're doing now is, you know, a truck will come by with body bags and they'll collect the patient and they'll seal them up in the body bag, and then basically the family doesn't see them anymore. And they either take them off to like a mass grave site, or they do the cremation, which some people aren't comfortable with that. So yeah, those cultural things are definitely a barrier. Well, I don't know, so I don't know, it's like a double-edged sword. So the media is definitely a very strong ally. So if you have a good public health message that you want to get out, there's almost nothing better than the media to help you do that. On the other hand, if you don't know what your message is, or you're confused about your message and you go on TV, then you're going to cause confusion. And then there are, you know, certain, you know, if you go on the internet, there's a lot of people that are putting stuff out on there that's probably intentionally confusing, or else they're, I don't know. But so I haven't really had that much problem with the media coverage of it. Most of it. Yeah. Like, I don't know. So the media outlet that put out that information that where Tom Frieden said, which I'm sure he didn't mean to say, but where he said you can get Ebola, or you can give Ebola, but you can't get it on a bus. I mean, you would hope that the media would, you know, more than trying to, like, you know, hurt Tom Frieden, they would like look for clarification or something. So, I mean, most of the media we deal with locally, they're trying to get the right message out. So if you said something like that, they would come back and say, is that what you meant to say? Or, you know, or they give you an opportunity to restate the thing. So no, actually in August, they said it was an epidemic of international importance. So like kind of warning all the other countries that expect cases to be coming to your area. Yeah, so, I mean, yeah, it's tricky. I don't know if some of you have worked in other countries before, but, you know, the Ministry of Health in those countries are the people that are in charge, and they have to invite you in. Like, you can't, World Health Organization can't just show up and start doing stuff. And like different, you know, Doctors Without Borders and, you know, missionary groups and stuff like that can't necessarily do things without the Ministry of Health allowing them to do that. So yeah, it's complicated. You know, there has to be, you know, the Ministry of Health has to be on board. But then you also have to have, I don't know, you have to have a coordinated effort and all the materials and things you need, which again, if you go back to that curve, you know, it would have been a lot easier to do all this when it was still in the initial phase rather than when it started logarithmically increasing. I think it definitely has been a gap of not having, you know, someone out there. I don't know that the Ebola czar is going to do the trick. And definitely in the past, the Surgeon General has been a strong advocate for different health issues, although it's always political, so what they can and can't say is always political. But certainly, you know, to have someone credible giving the right messages, you know, is always helpful in a public health situation. And I think, I don't know, like with the case in Dallas in particular, I think that, you know, there just wasn't, you know, whether Dallas wasn't ready for expecting to ever have a case, so they were kind of trying to play catch up or whatever, but just didn't, the results did not turn out that well.